We're very pleased to have today some veterans from San Diego Fire. We have Captain Chuck Adams and Ted. Hold on, wait. Ted Chialtis. It's Greek. Who's Greek? Ted's an engineer, and and they've both been with San Diego Fire for 10 years.
Yep.
So they're going to talk a little bit about their protocols. I don't know if you know for sure, but every July there's new protocols for the paramedics that are put out countywide. So you got to know the old ones to know what's different in the new ones. So they're going to explain some of the changes that came up this past July. Thanks.
Good morning. My name is Chuck Adams. Like she said, I'm a captain paramedic. I've been a paramedic since '99. I've been with San Diego since 2000, and it's a pleasure to be here today. Ted is my colleague here today. He's been a paramedic a lot longer than I have.
21 years.
21 years. And so we both work together at San Diego Fire Department. We also both teach at a paramedic school out in Lakeside. Ted's the paramedic coordinator for that program, and I'm one of the assistant TAs and do most of the skills lab stuff. Our presentation today, there's basically two things. One of the things that I saw in your syllabus is what's new or new things for us. So what we did was we highlighted some of the new protocol changes that are just basically trauma oriented. And then our second portion of the presentation is just going to be something quick about a C-spine controversy that we have. And basically it's just designed to try to spark some dialogue back and forth with all of you. So if you have any questions, that'd be helpful. And Ted will take it away.
I will. Good morning, everybody. Let me see how this thing works. Okay, very good. So as Chuck said, we're going to be just reviewing some of the new protocol changes for you for San Diego County very briefly. And we tried to focus on those that specifically affected you and our patients with regards to trauma. So we didn't give you a lot of medical stuff. This is going to be what we're going to talk about today is more specifically trauma related, and we think would probably be useful for you. And for sure want to inspire a lot of questions and discussion from this as well. Also want to give you a unique opportunity, because since you're all trauma resuscitation nurses at the end, to tell us what you think about the paramedics that bring patients into you, and if you have questions for us with regards to that. We've certainly brought our share of patients to the trauma resuscitation rooms and are involved with people who do that as well. So I want to open that up to you today too. So we'll start off with the topic of shock, and this is one of the changes that's taken place for this year. They change our paramedic protocols in San Diego County every July after going through a fairly strict revision involving a large team of physicians and nurses and some paramedics as well. And so here's some of the things that are fairly new with regards to our treatment of shock patients, and even specifically the hypovolemic shock patient, which, as you know, of course, is going to be the majority of our traumatic shock victims. So here's one of our changes with regards to this. And it focuses on blood pressure. We've always used the blood pressure of 90 systolic as sort of our goal when administering fluid boluses to shock victims from hypovolemia, and that's recently changed as a result of numerous studies which have shown that too much fluid can actually affect these patients in a negative way. So they've changed our goal to now being 80 systolic instead of 90 systolic, consistent with many studies that have been done. It's a little bit of a difference for us, but that is one of the changes. And we also give our fluid boluses, you might not know this, we give our fluid boluses in increments of 500 milliliters at a time, and then in between each one, of course, we'll reassess vital signs and breath sounds, lung sounds, to make sure that they're not overloading on fluid. Here's another big change. I don't know if we have a pointer on here, but the one that says if MTV multi-trauma victim, IVIO en route. And this just reflects the knowledge that time spent on scene with a multi-trauma victim, especially one who we suspect is hemorrhaging, is time lost for that patient. And we recognize the fact that there's only so much the paramedic can do for these patients while on scene, and there's a lot that you in the trauma resuscitation room and possibly subsequently in the surgical suite can do for these patients. So recognizing our own limitations has helped to make this change. That is that we are not going to be doing very much in the way of treatment for our multi-trauma victims who we suspect are hemorrhaging on scene at all. And so this means we're going to spend very little time there. We'll do very minor things such as airway control and usually control the spine, package the patient, and then be off the scene. And our goal, of course, is 10 minutes or less with these patients on scene. Sometimes that's easy to do, if you can imagine, say, a stab wound or a gunshot wound that don't require as much packaging. Other times, if it's a patient who, for example, is involved in is trapped in their vehicle, could be a lot longer. But the goal is 10 minutes or less on scene, and we're not going to be doing much in the way of treatment there. Once we're en route, we'll begin more of our treatments, for example, the IV or IO if necessary, and those fluid boluses. The whole focus being to do the treatments that are necessary while en route to the trauma center, get them to you guys as soon as we possibly can, where you can make those definitive determinations and then take that patient to surgery if need be. Another change for us has been involving needle thoracostomy, and the only real change here is that we've been able to do needle thoracostomies now for suspected tension pneumothorax for quite a few years, but now they've changed this to a standing order for paramedics, and so we no longer have to go through the process of getting a base hospital order when it originally actually was a physician order. And we can now, if the criteria exist for a needle thor in the field, we can actually do these on standing order, and which is a good thing for the patient because it gets that treatment to them much sooner. And you all know this is for sure a life-threatening condition for the patient. So that lists the criteria: severe respiratory distress with unilateral absent breath sounds, blood pressure must be 90 systolic or lower, and the patient, this is a little bit confusing, should be intubated or positive pressure ventilated. This does not mean that we have to intubate them to engage in the procedure. What this means is they should be sick enough that we are already controlling their airways with positive pressure ventilation and possibly intubation, and then if they're sick enough and have these other criteria, we can insert the needle and decompress their chests. Another slight change has been involving the location. This has gone back and forth a few times over the years for us, where they've talked about anterior placement of the needle versus lateral or axillary. It's changed 2 or 3 times now, but we're back to placing them anterior as the preferred site. What do you guys prefer in the trauma room? Doctor specific? Yeah, whatever's best. Yeah, the amounts of tissue here versus there. Again, we've changed it several times, but now we're back to being told that we should be looking anterior first, although we can do axillary if we determine that's a better site. So there you go. And that may be why they've changed it for us. I've always thought it was just easier to get it in the anterior in the axillary, just because there tends to be less tissue, but either way, this one's more forward, so we'll do what they want us to do. And I'm not sure whether this is study supported or just, again, the doctors prefer it that way, so that's what we're trying to accommodate. Okay, spinal stabilization is something we're going to talk more about in detail with a subsequent presentation, but for now, just to touch on this, this is our criteria pre-hospital in San Diego for when we spinally immobilize a patient. Meaning full spinal precautions from head to toe. You should never see a patient brought to you with partial spinal precautions in place. They should always be spinally immobilized all the way from top to bottom. We don't use short spine boards here, only long spine boards. But here are our criteria. They've made this, and here's the change as well. We used to pretty much C-spine every patient with injuries above the clavicles due to suspected mechanism of injury. It was sort of a given that we would, whatever their mechanism was, if they had some injury above the clavicle, we'd put them in C-spine precautions. Now they're relaxing that just a little bit. This is also study-based and saying that if there's no neurological deficits and all the following are present and documented, being these things: patients less than 65, they are awake, oriented to person, place, and time. We don't suspect they've been using drugs or alcohol. Well, how many of our patients aren't? But yeah. Don't complain of pain, tenderness to the neck or back upon palpation there, no competitive pain, and no language barriers exist, then we can choose not to place them in spinal immobilization. And again, we're going to get into this a little bit more in detail with you later. There's always talk about this topic, so we'll come back to it. But here's our criteria, and we're having trouble making some adjustment to this because we're so used to C-spining everybody. Now they're telling us we don't have to. But we'll talk about when we do or don't. This one just has to do with base hospital contact criteria, and as you may know, paramedics, we always call a base hospital, a number of base hospitals throughout San Diego County, UCSD being one of those, with each of our patients. And this change just involves making early contact, especially for trauma patients, as opposed to calling them at some point later. This is good for you in the trauma room because it gives you more advance notice that you're going to get a trauma patient from us pre-hospital. So it's partially for that reason, and it's also, it comes back to conditioning the paramedics to think short scene time, rapid transport, contact early so the hospital's ready to receive, so the trauma team is ready to receive you. And it lists a few criteria here with regards to adults, pediatrics, and for our pediatric patients, SHARP is our base for the trauma patient, and for burns, of course, UCSD. Okay, I wanted to give you a little bit of terminology that's important to you, and this one is also a change for us, involves definitive therapy, and this is another thing that we're finding some trouble adjusting to, and mainly has to do with administering an IV to the patient. usually kind of a given in a trauma patient that we're going to be giving them an intravenous line. But our protocol specifically state definitive therapy is that which is in which we have immediate or anticipated need for the administration of a fluid bolus or medication. So they've just added that to the definition of definitive therapy. And this is there to help us decide when we shouldn't start an intravenous line on our patients. If we anticipate we're going to be giving a fluid bolus, we will, or medication. If not, we're actually not supposed to start IVs. But how many of you, let me ask you, how many of your trauma patients that come into the resuscitation room, even those that are not critical, have IV lines in them? Would you say all? Pretty much all. And this comes back to our controversy about C-spine too, and we'll talk about the paramedic fear. We're afraid of a few things, and it's usually not the patient deterioration that we're afraid of. It's something else. Okay, here's just a definition for you for shock, and I don't necessarily know what the change of your career is shock to you. For the under 15-year-old person. Okay, another thing we were asked to talk to you a little bit about today was airway management. And so that's what this has to do with. And when do we manage the patient's airway? How do we decide whether we should just use Bls airway control, intermediate airways, or advanced airways like the ET tube? And paramedics actually can intubate patients in San Diego County, although without the luxury of RSI. You may not have known that either. So you might wonder why patients are coming into you not intubated. Sometimes it's because we can't paralyze them first, and they're not intubatable for us out there at that point in time. But here's the basics for our airway management. We will always start with BLS, and the basic criteria there is if the patient is unconscious or we suspect can't control their own airway on their own, which is any unconscious patient, then we're going to insert either an oropharyngeal or nasopharyngeal airway adjunct to start with, based on their type of trauma and which one we prefer. And gag reflex and other things. So we'll put that airway in. We'll give them some basic airway maneuvers, of course, being cognizant of possible spinal trauma. And then we, if necessary, will of course ventilate them with a bag valve mask device just to start. So that should be the minimum. Bls airway control is making a comeback in EMS as being an actual great way to control a patient's airway, and they don't always need to be intubated. So we recognize that as well, and we can see our protocols sort of not shifting away from intubation, but helping us understand we can do a great job of ventilating patients with Bls airway control.
But that's kind of compartmental capnography.
Yes, capnography is a big part of it. We'll talk about too.
Years ago we didn't have capnography, so now with capnography, we're more relying on the capnography numbers coming back to us positive and saying, hey, wait, we've got the airway controlled as is with BLS measures. Let's not, or we don't have time to, we've got to pick and choose which procedures we're going to do in route. We can opt out of intubating the patient because we're looking at really good capno numbers. So that's been the biggest change for us.
That came about several years back. We started to use capnography in our. So the paramedic may make the decision to intubate a patient in the field pre-hospital, and again, we do not have currently in San Diego the luxury of RSI. We also recognize that you do, and so we know that. We also realize getting a patient to a place where they could be intubated with the definitive airway we all know is the ET tube faster can make a big difference to them. But we have the ability to do so, and our criteria are these: if the patient's apneic, which makes it easy, we can do this, or if their respirations are ineffective. And also unconscious or have a decreasing LOC. And those are the ones that create a potential difficult advanced airway for us because, as you know, when they're not completely unconscious, they may be clenching down, they may be trying to fight that process, and it's not a comfortable process. So we may have to fight against the patient. That creates a situation for the paramedic where you have to decide, am I helping this person by fighting against them with my laryngoscope blade, or am I hurting them? And we have to think about that in our decisions. So again, well, we kind of can. We have the best one we've got is Versed, and it's in a benzodiazepine. It's not intended for this purpose for us, for paramedics. We mainly use it to treat seizure patients and prior to synchronized cardioversion and a few other things. But it's not in our protocols to give as a sedative prior to intubation, although it's been shown to work fairly well for that. And so for a paramedic to get that done, we have to actually involve the base hospital physician on the radio, and he or she has to then give us that order, which takes some time. The results are mixed. Some patients seem to get quite relaxed with some Versed, and other patients not so much. So it may help us get the ET tube in there, or it may not. I know it's a fairly common request for, probably the most common physician variation from protocol request that we give is for this particular one. Again, mixed results there. It's not been shown to be effective enough for them to actually make it part of our protocols to do.
That's kind of what we were, some of us, at least myself, I was kind of hoping that the RSI study that we did a few years ago would actually result in a protocol change to include us to be able to use paralytics or percent at least in our protocol as a standard to intubate difficult patients, but it didn't happen for us.
Well, we have a lot of patients come in, I don't know how many doctors who get 10 milligrams per set IM because they're unruly. And
Yeah, that's the protocol.
Yeah.
That's another reason that we do give it is for the combative patient, but not due to, well, it actually can be due to head injury, so it depends. We can apply that protocol to maybe make it easier to intubate patients, but we just don't have it specifically for the purpose of relaxing a person prior to intubation.
But we do have a radio, so if we have a cooperative doctor and it's a good paramedic who does what I call a goal-oriented radio report, we get someone who gives exactly the information that's specific to the need, very clearly and paints a good picture, and possibly the doctor will, help you out in that regard. But, one backup thing is the King airway device. So, on a really bad airway that we can't intubate, we can use blind insertion with the King. So,
Works fairly well, and the King airway is easier to insert, especially with a person who's in spinal precautions, because you don't have to manipulate their airway much at all. If they are relaxed enough or unconscious enough to take that airway, then it works quite well for it. So we make this decision somewhat of a dilemma. Do we go with just Bls Airway Maneuvers and airway control that way with bag valve mask? Do we use an intermediate airway like the King, or do we go to full ET intubation? And it's all specific to the patient and their level of consciousness, I guess you could say, or combativeness in some cases. This isn't really I guess it's fairly new, about the last year or so. We've been required to place a cervical collar on all patients that we have intubated, and that's just to help keep that ET tube in place. And before we weren't doing that. Now, in the case of trauma patients, most of them, again, were already in spinal immobilization, so this is less of an issue for the trauma patient. But for our medical codes, for example, we place seat collars on them just to keep their airway straight and decrease the chances of extubation. Okay, so just a few things we wanted to bring up about what other things are fairly new. These are not necessarily trauma specific, but you may not know this and may be interested. In our EMS community now, most agencies are now able to transmit the 12 lead EKGs that we obtain. We've been able to obtain 12 leads for quite a few years. Now we can transmit those 12 leads directly to the receiving facility, and then they have them before we get there, so the ER physician or cardiologist can take a look at those and more or less confirm our conclusion and our monitor's conclusion. And so we found that to be somewhat helpful. Electronic patient care reports, again, now being able to be transmitted to the receiving facilities so that they have a copy of those things. Usually it's by the time we leave the facility, not before we get there. And that goes to the patient's chart, patient's record. In the city of San Diego, we have two helicopters that are part of our system. Their primary goal is fire suppression and also patient rescue, for example, patients who are stuck on cliff sides or other difficult extrication locations. That's the primary goal of the two San Diego Fire helicopters, but they're now being utilized on a limited basis for patient transports. As you probably know, Mercy Air is the contract transport air provider here, and so this is not designed to take patients away from them, but in certain situations it's determined to be best for the patient's outcome for if we're going to rescue a patient to just fly straight to the receiving facility rather than doing some kind of a rendezvous. So we're starting to see them used a little bit more for that. And there is a paramedic that staffs Copter 1 and Copter 2 24 hours. And then something that's sort of coming but is not yet in place is there's apparently a new mass casualty policy for our county that's about to come out, I think within the next year, Chuck?
Yeah, I think actually we're training it like in the next month.
So to replace the current Annex D situation that you probably heard about, so something that's new. And we don't have specifics on this, but we just know that it's something that's changing. Okay, so that was a real brief presentation for you about some of the new protocol issues. We have another one to come about C-spine, which is probably one of the biggest points of controversy. So we will go to that next. But before we do, any general questions about these things?
Is it tough to start an IV or an IO in the rig more difficult than on the scene? Will we see more IOs?
Well, we shouldn't be starting them on scenes on our traumas anymore, so hopefully we're not. Some exceptions could be, say, a patient is pinned in a vehicle, we have to extricate them. That extrication is taking some time, so we might actually do an IV while we're getting them out of the car. But other than those types of situations, we shouldn't be starting them on scene. Is it more difficult to start them en route? It is, but it's something the paramedic actually gets used to doing and needs to be good at. So we train at that. We should be doing all of our trauma IVs on the road. And we have good drivers and we have bad drivers, and we have smooth roads and we have bumpy roads. And so it's definitely a challenge for us. And the ambulances are not, they are not designed for smooth performance in the back. They're basically trucks with a big box on the back of them. So it becomes challenging, but we actually get fairly good at it. You learn to time your stick with the bump in the road.
Has your frequency with the IO increased? Because that was last year.
Yeah, and that's a great job for the captain or the engineer paramedics, because the way our system works is there's obviously a captain, an engineer, a firefighter paramedic, and a firefighter EMT on every apparatus. The firefighter paramedic's primary responsibility is all the patient care. His partner, the firefighter EMT, I like to jokingly say the PMA, the paramedic assistant, because he basically is the right-hand man of the paramedic. It's all the vital signs, does all the packaging stuff, but all the skills are basically done by the firefighter paramedics. But as the firefighter paramedics are busy managing airways and that sort of thing, and they need IV access or an IO, it's the perfect job for the engineer paramedics, because we still have our paramedic certifications. We can jump in and assist with those types of skills. But as the IO, it's gotten more and more common. We've all basically lost the little phase of fear of something new, so now we're getting really good at them. On cardiac arrest especially, where IO is almost the first thing we do anymore. We hardly even look for an IV access now. We just go right to an IO because it's so good. So I think as more people in the system at least become like me, very comfortable with IOs, I think you'll start seeing them a lot.
Are you seeing more patients coming in with IOs from paramedics in the trauma room yet? Yeah. Well, and I'm thinking that the demographic.
The ED is seeing it more for the color.
Yeah, for medical cardiac arrest. But I'm thinking the demographic for trauma patients, I don't know the numbers, but you do, are probably mainly young men who generally have pretty good veins. So unless they're completely bled out or shut down, we're probably going to be able to find a decent vein on them, and so we're pretty good with the IVs. And most likely you're going to continue to see IV lines on these patients. Okay, any other questions? Just general.
Refresh my memory. What's your King Airway?
Oh, okay. I wish we would have brought one to show you. King Airway is sort of an evolution of the old the combi tube. So it works similar to that. It's a dual lumen airway, so there's two side-by-side passageways for air. It may, for the most part, a balloon will block the oropharynx or enclose the oropharynx, and then it doesn't go into the esophagus, but stays right about there, leaving the end of the tubes just above the vocal cords. So
the biggest change, though, is that there's one tube to put the bag valve, two to the bag, because it used to be if you bagged the wrong one and you didn't recognize it, and there was trouble. So now there's just one attachment, so that makes it very simple in the field.
And it actually could, just by luck, make its way into the trachea, in which case it's an ET tube, and if it doesn't, it goes in the esophagus, or just down into the esophagus, then there's another, the air will come out a different port above the vocal cords. So good alternative airway, relatively non-invasive, and it's done blind.
This is the presentation that was prepared by our chief of EMS, Chris Brainerd, and it's basically our C-spine controversy. And for us, it's like a never-ending thing. And I noticed that some of the protocol changes that are in here are actually protocol changes that almost seem to be inspired in some cases by the paramedics, saying, could you please put this in there? For example, the IVs en route, because as the captain and the engineer paramedic, if we're not the ones that have our hands on the patient, we're actually stepping back, watching scene safety, seeing what other things need to be taken care of. We're the ones that are mostly feeling the time elapse on scene, and we're going, what is taking so long? And it's not uncommon for us to poke our head in the back of the ambulance and say, how's surgery? How's it coming back here? Because they're on scene way too long. So it's as if that protocol phrase was put in there to try to get the protocol to back the paramedics to get off scene quickly. So as the biggest thing is our C-spine controversy. C-spine in San Diego, we do 10,000 C-spines per year, and that's because when you look at the mechanism of injury on any vehicle accident, and then you can basically make any patient you want to fit into a C-spine protocol. And so many paramedics are afraid of lawsuits and getting in trouble at work, that sort of thing. So when in doubt, break it out is what we always say. Just C-spine the patients. So all other splints applied in the field, only a few hundred as compared to 10,000 C-spine cases in our system.
It's also the largest source of lawsuits against the EMS agencies is C-spine related issues, other than AMAs. So it's actually the second largest source. AMA is the first, and C-spine is second. So we're worried about that.
So it's a concern everywhere in the country. A couple of questions. Is there any evidence to support or justify this level of concern? And I think there is. Actually, I guess we could sit and debate it for a while, but when you do hear about a lawsuit or even just local discipline within the system for not putting someone in spinal precautions, it does definitely resound to everyone. So people get afraid to not put someone in C-spine. And then the question is, are we hurting any patients? And I think most of this stuff and the controversy surrounding even IVs using definitive therapy, it depends on the paramedic and it depends on the supervision, I think, a lot, because Ted could be the type of person that wants to do everything right and always errs on the side of safety for the patient. Well, I could be the guy that's burned out, I'm tired of it all, and I just want to do the least I have, that's expected of me. And I hate to admit it, but that exists in our fields. I mean, I'm sure it exists in every area of healthcare. But if I want to, I can fit my patients into C-spine, or I can try to squeak them out of it by, maybe downplaying the mechanism of injury, for example. But I think when I'm talking about, are we hurting patients? Are there patients that actually would be better off in not having C-spine precautions, or even what we'd call a modified C-spine precaution, like a very kyphotic elderly female? I've seen times where we just put on a C-collar the best we can, or we just use blankets and tape and a semi-sitting position. But then it totally depends on the experience of the paramedic, because not only is it the field experience with the paramedic, but it comes down to how a paramedic's experience interfacing with the nurses. Because for me, I'm very comfortable if I take a patient to a nurse, I expect the worst, but just to be defensive, I'm prepared to answer every question. You know what I mean? I expect to be basically given the 20 questions to basically justify why I've done what I've done. That's what I mean by that. So what I mean is, I'm going to definitely look at the mechanism of injury. I'm going to do a very good patient assessment, have a full set of vital signs, but I'm going to be erring on the side of the patient, and I'll be ready to explain exactly why I've done what I've done. Because there are instances, and I've actually, as sad as it is, I've actually gotten into a debate before over why I didn't C-spine my patient. So ever since that day, I've just always been prepared to be on the defensive for why I didn't justify, or why I didn't C-spine a patient. So
we just roll our eyes and go, get aboard, or whatever.
Yeah. Yeah. But again, it falls back to the paramedic. No, it doesn't. It's not personal, and it's only the rare instance of that particular nurse that might, make me feel like,
Is that
feel that. But
you shut up.
it also, the thing is, you could get a paramedic who's totally not comfortable with the interface between the nurse, and they're not prepared to have the debate or justify why they didn't C-spine a patient, and they're going to force that 90-year-old kyphotic woman into C-spine. And for us to look at it as the engineer and the captain paramedic, and it's a nightmare. Because you want to do what's best for the patient, but it's the paramedic who's transporting that patient and ultimately has to turn that patient over to the doctor, or, to the nurse, and possibly to the doctor. And it's always when you do something a little bit sketchy is when you get a turnover to one nurse, and then another nurse might be trading, and it's going to be her patient now, and then lo and behold, the doctor comes in, hey, what do you got? So if you mess up, you have to give the turnover like 3 times. It almost never fails. So.
Where do you guys stand with a fall from standing that doesn't have any neck?
Great question.
Yeah. Let me get to the slides.
We're actually going to answer it in the slides.
So are we still afraid of lawsuits? Yes. Is it controversy or fear?
Remember we talked about fear earlier. Here we go.
Dr. Shackford. He suggested, according to our protocols, are our protocols rigid protocols, or do they allow for some intellectual flexibility? And I personally am a huge fan of the intellectual flexibility, but you have to have confidence too. If I'm a first day or a first year paramedic, I may not have the confidence, even though I might be intellectual enough. I'm scared to death of that turnover. You know, that's what I'm thinking of. I've got to turn this patient over. I have to put them in C-spine.
So we want to have intellectual flexibility. That's what they're trying to encourage us to do, and that's what we want to do. But we find ourselves falling back on the rigid protocol once again. This has been around forever. I just want to add a really quick story, Chuck.
Yeah.
A few years back, I went to an EMS conference in Baltimore, probably one of the biggest in the country. And there was one of the topics, one of the breakout sessions at the conference was to C-spine or not to C-spine, which is kind of like what we're talking about today. And as a veteran paramedic and an instructor, I thought, finally, I'm going to know the answer to this question. So I was the first one at that little breakout session to hear the talk about C-spine or not to C-spine. And it was about an hour long, and at the very end of it, you know what the conclusion was? When in doubt, C-spine. Yeah, so didn't gain anything new, and time has passed since then, and here we still are with the desire to be intellectually flexible about spinal mobilization, mobilizing patients, yet the fear exists, and that's what we're still talking about.
Are there lawsuits that you C-spine or didn't C-spine?
The majority of them, of the lawsuits, come from patients who weren't C-spined, who we apparently should have, or the lawyer thinks that we should have.
And that would fall.
They do go in both directions.
And I got to speak for paramedics in general when I say this, but I would be totally afraid of a lawsuit because I didn't do something rather than I did too much for them. If I C-spined them and then ultimately I got sued because I C-spined them, unless my procedure was totally flawed, I would be scratching my head and wondering how could I possibly get sued for putting someone in spinal immobilization? That's what I'm here for, you know? So the fear comes from not doing it. And then again, it goes back to what we were talking about either. Paramedic A lives that fear every day and is totally concerned about it, and they want to do it because of what's best for the patient or the fear of getting in trouble or sued. And then the other paramedic says, I'm not even worried about it. I've been doing this a long time. I've never been sued. Don't put him in C-spine. Just put him in the back. I'll take care of it. I'm not afraid of, anything, basically. The nurses, yeah. So. Let's be real.
The fear. The first half of the fear for us is the lawsuit, the potential for a lawsuit. The second half of the fear is you.
Well, here's the thing. At our facility, I just have to say, it's the residents and the physicians that are talking with you guys. The nurses don't open their mouths. We take the calls and we stand on either side. But you're actually talking to residents, and a lot of them are female, so you may. We have learned over the years to really keep our mouths shut and try not to roll our eyes because of, for us, all it involves is, okay, now we have to get the board, we have to put them in the season. So it's just a step. But honestly, we're the ones standing with your mouths open.
In the trauma room, absolutely. We're
Your looks are powerful.
This controversy more comes to play in the ER rather than the trauma room, because that's where we bring these questionable C-spine patients. Clearly, if they're in trauma, most of them need to be in C-spine, or probably should, depending on their mechanism. So we'll talk about a couple different things.
See, I think since you guys are teachers, you guys need to get over that.
We're in a
If you guys do something wrong or something, you see something that's not right, you guys need to be able to take that.
We do.
Criticize them.
We do.
And just get over the fact
We
that
get
we
told
are
that you
trying to
guys
take
don't
our patients too, we're not going to give us.
Yeah. No, that's a great point. We do teach
Shepherd always preached, do not think, is do follow the protocols. That was his philosophy
Yeah.
30 years ago.
The way I put it to a student a lot is look at we'll do just simulations with the students, and I'll give them a patient, and here's all their injuries, etc. And then I will, if they're not doing things that I think that they should be doing for the patient, I'll say, okay, stop for a second. If I were to give you a written test, and I would say, circle all the multiple choice treatments that you would do for this patient, would you circle C-spine, and would you circle oxygen, and would you circle IV? And they, yeah, of course. Then how come you're not doing that on this patient? And then again, you're trying to discourage them from thinking too much. And then I always say, if it's a gray area, if the mechanism kind of, and it's a little bit of neck pain, and I'm not quite sure. If you ever even find yourself saying that or feeling that way, I say put them in C-spine. And then there are several exceptions. Of course.
If we were in a teaching hospital, they're going to have protocols because we have residents rotating monthly.
So they don't-
You can't let them think that much. I mean, it's because, you know, it's just you have to have protocols. And that's why
And then
we're not
here's
gonna
our
do guys.
protocols. For the 5 no's to rule out C-spine, it's if they have no neck pain, no altered mental status, no impairment by drugs or alcohol, no competing pain, and then no mechanism that's suggestive of the need for C-spine. And then obviously one of the other ones was the patient's age less than 65 years old, there's no language barrier. So if they meet all this criteria, you don't need to do C-spine. I think the main feeling from this whole issue for us is that we as paramedics also see that this patient does not need C-spine and would be just fine in a position of comfort, doing the best thing for the patient. And we've always looked for the protocol to kind of back us up on it. Unfortunately, the protocol has always kind of pushed us to not think and just C-spine everybody because they fit the protocol to C-spine. Now with the no neurodeficit being on there, you know, and there's a scenario in here I can give you real quick. So, true or false question, paramedics are afraid to bring a patient to the trauma seat without C-spine. True. It's true. We're afraid. We're afraid to bring a patient to the trauma seat.
Would you like to see us bring fewer patients into C-spine?
Well, but for us, we're just gonna have to put it back in, so.
Yeah. This patient's like 50 years old, so vehicle accident. Moderate front end damage, abrasion to the nose from where the airbag went off. The patient self-extricated, so is walking around talking to PD when you arrive at the scene. And the vitals are within normal limits. And the patient's got, you know, doesn't meet all the, he's got no loss of consciousness. He's oriented ×4, no alcohol on board, and no neck or back pain. Does the patient need to be in C-spine? I would put that patient in C-spine. Mechanism injury, exactly. Yeah. Yep. And then, you know, for the one who's looking for a reason not to, they might, you know, use the fact that, well, the patient got out and is already talking to the police. So after strong encouragement from paramedics, the patient agrees to be transported to the hospital. And then during transport, the base hospital upgrades the patient to a major trauma. Now what? If I didn't C-spine my patient. So I'm transporting my patient that had that minor vehicle accident, no neck or back pain, no ETOH, no loss of consciousness, everything's fine, vitals within normal limits, minor abrasion to his nose, but now the MICN has just upgraded my patient to a major trauma. So what do I do now? Believe it or not, crews have pulled over to put C-spine on the patient. You know? I mean, yeah. You gotta have, yeah. You gotta pull over. Hey,